Hi everyone, this is Rachel. For those of you who do not know, I am an IBCLC and International Board Certified Lactation Consultant, as well as a nurse. I've worked for a very long time in OB, pediatrics, even NICU, nursery. And for today, I wanted to go over breastfeeding. This is going to be a wonderful crash course. It's going to go over the basics of breastfeeding, milk supply, and also, of course, how to overcome some really common breastfeeding barriers.
Mommy, did you know?
First of all, let's go over some basics of breastfeeding. Of course, I love to go over the benefits. So there's so many benefits for both mom and baby. For baby, it helps to prevent infection. It helps from diarrhea even. So babies that have breast milk, mostly, they're going to have a little bit more development of their GI system. They're going to have better microflora as well in their gut. It even helps to prevent otitis media, late onset sepsis in preterm infants especially. So if you have a preemie, what's really interesting is that your breast milk is especially composed for exactly what the baby needs at that moment in time. So preemie babies, typically the breast milk is going to be a little bit different. And it even helps to prevent sudden infant death syndrome, which of course is on the back of every mom's head right after you have a baby. So sudden infant death syndrome is an unexpected death of a baby, which happens for a seemingly unknown cause, just for a healthy baby. That's the biggest thing, is a healthy baby. So breastfeeding actually decreases the risk of sudden infant death syndrome. One of the little theories that they have is that breastfeeding actually encourages a wider and more open palate. Then with that wider, more open palate, it has a more open airway. Also, breastfeeding babies tend not to sleep as deep as formula feeding babies, rather than, they're more easily startled, especially if they're having respiratory issues. So there's a bunch of benefits for babies: better immunity, better GI system, less risk of even diabetes later in life, sudden infant death syndrome. So all of that great stuff. Now for moms, a lot of people don't realize that there's a lot of benefits in there for moms as well. Moms, we don't like to talk about the weight so much, but one is it helps to decrease the size of the uterus. It helps the uterus to go back to its original position. Now, breast milk has a lot of different hormones at play in order to create breast milk and to release breast milk. One of the hormones is oxytocin, which is the hormone that releases the milk. Oxytocin also travels to the uterus to cause it to go back to its original position, its original shape. So moms who breastfeed, typically they're going to have a little bit more cramping in the beginning. However, their uterus is getting back to its original shape. It also lowers the risk of osteoporosis. It actually is very interesting because during pregnancy, your bone density actually decreases a little bit to make room for the baby. You're going to need a lot of flexibility as the baby's born. Now, once you wean the baby, all of a sudden your bone density goes psh. However, you need to breastfeed for about 6 months in order to have the benefit of that, where instead of having a lower bone density, you'll breastfeed for at least 6 months. And then after you wean, your bone density actually increases drastically. Lowers the risk of cancer, especially breast cancer. Breast milk has these really interesting cancer killing cells called Hamlet cells. Regulates blood sugar. Studies actually show that breastfeeding actually decreases the need for insulin as well. Regulates blood pressure, decreases risk of postpartum depression, especially with support. Helps moms to bond with their babies and prevents hemorrhage after delivery. That's for the kind of that extra stimulation to the uterus to get the uterus back to its original position. Now, with all of these benefits, what are some tips for success? Number one is make sure that you are being supported by either lactation or by having these classes, such as before you deliver, so that you can kind of understand the basics of breastfeeding and how to overcome some common barriers that you might face. Also, try to do skin to skin as quick as possible after the baby's born, especially in that first few hours of life when the baby's transitioning. Try to do skin to skin and initiate that breastfeeding session as soon as possible after birth, and try to have as uninterrupted time as possible. Now, the science of breastfeeding. Now, how does breastfeeding work? What's the terminology behind it? So the breast has the nipple, of course, these are just the different parts of the breast. We have the nipple, we have the areola, and then of course we have the breast itself. but inside there's a whole bunch going on in work here. So Montgomery glands are these little glands that secrete these microscopic secretions that help the baby to find their way to the breast, actually by smell, because newborns don't really see that well. More than anything, they smell. So it helps them to find their way to the breast. We also have the dark part of the breast, which is the areola. That's also the part where you need to compress. Compression of the areola and stretching of the nipple will help to release the milk with that oxytocin. If you are, however, let's say you're shallow and you're just on the nipple, and you're just compressing the nipple, you're not really going to be stimulating all of these muscles and all of these milk secreting cells like you need to. Now for hormones, we have prolactin, which is the milk producing hormone, P for Pete. And we also have oxytocin, which is the milk letdown hormone. You need to have a combination of these in order for breastfeeding to work. Prolactin, the milk producing hormone, is released by a negative feedback system. The more that the breasts are drained, the more the breasts fill up. Therefore, the prolactin will be released the more that those breasts are drained. The oxytocin is the milk releasing hormone. That is released by breast compression and nipple stretching. If we are not latched correctly, that's when we might not be able to stimulate as much as possible that letdown. So some parents can feel that letdown, some moms can feel it after a few weeks or days postpartum. Majority of women take a little bit of time. So even though you have the baby and you might not feel a letdown, does not mean you don't have one yet. Sometimes it takes a little bit for people to feel that letdown in the beginning. But at first, the first few days, mom have colostrum, and then that colostrum is very thick, can be yellow, can be clear, and it is jam-packed with immunities and everything that the baby needs. Now, mature milk usually takes about 1 to 3 days to come in. It doesn't mean that you don't have a milk. It just means that the composition of the milk is different. The colostrum is like an antibiotic shot. It's drops and it's not as copious of a milk supply as much as the mature milk, which has a lot more water, a lot more lactose. The way that your milk transitions more effectively is by stimulation. So the more that you are stimulating the breast, the more milk that you will be able to produce. So at first you have the colostrum, lasts a few days, then the colostral phase can change to the mature milk phase. Although it does take a few weeks for kind of your milk supply to establish itself. The more that your breasts are emptied, the more prolactin is released. The better that the baby's latching on the breast, the better that letdown will be as well. Now, how can you use the knowledge of milk supply to your advantage? Well, the biggest thing is to understand these hormones and what's going on, and also how it can affect if you are breastfeeding, especially if you're breastfeeding exclusively. So for example, we were talking about our prolactin. So prolactin is that milk producing hormone, which is released as the breasts are released, as the breast is emptied. So you think to yourself, all right, let's say I have a low milk supply. What do I do? Well, you go back to step 1, stimulation. All right, I want to produce more prolactin because I have low milk supply. What do I need to do? I need to drain my breast more frequently. So that's step number 1. So a lot of times I'll have people say, oh, I haven't been pumping much because I'm not producing much milk. That's actually the reason probably you're not producing much, is because you are not stimulating the breast. Or if we have a mom who's breastfeeding and she has a lower milk supply, and sometimes they get discouraged if they're not, producing that much. So then they try not to stimulate that much and they go straight to the bottle. So what we want to make sure is that we are having stimulation. If we're not having stimulation, there's no amount of lactation cookies that's going to take the place of stimulation, because it all goes back to the more the breasts are drained, the more milk is produced. The more the breasts are drained, the more milk is produced. So it's all stimulation. If you have a low milk supply, you want to stimulate as much as possible, but baby to the breast, maybe pump a little bit after if it's needed. You also can consult with lactation to see if you have a true low milk supply, because sometimes people think that they have a low milk supply, but that's not really the case. But keep in mind all of these basics that you can use it to your advantage. The areola is where you need to compress. So okay, I need to make sure that the baby's latched on well. Now, how do I latch on the baby well? So we know that basics, all right? We know the nipple, we know the areola, we know that the babies use smell to latch onto the breast. We know the benefits of breastfeeding because we talked about that as well. How do I latch on the baby? Well, the first thing, and one of the most important things, is preparation of when to start the breastfeeding session. So you want to start at the early breastfeeding cues, not the late breastfeeding cues. So a lot of people go, oh, my baby is sleeping, I'm not going to start the breastfeeding session yet until they wake up and start crying. Well, what ends up happening is they're very aggravated and it's very difficult to breastfeed a baby that way. So instead, you start at the early feeding cues. You see the baby stirring. You see the mouth opening. You see the baby turning their head. Then let's say you let the baby sleep a little bit too much, and then they start waking up a little bit more. They go, I'm really hungry. And their hand to the mouth, they're increasing their movement. They're kind of more jerky with their movements as well. Then it gets to the late signs, which is when calm me, then feed me. Don't try to feed a baby if they're crying directly to the breast, because it's not going to end very well for you or the baby. But that's some late feeding signs will be like crying, aggravated movement, especially like kind of excessive rooting, kind of things like that. Now, what you want to do is make sure that you are starting your feeding session when the baby is starting those early or even maybe mid feeding cues, but you don't want to wait until it's too late. So you want to see when the baby is kind of starting to open up, or the best time is when they're kind of in that quiet alert phase. Want to do as much skin to skin as we can. We can room in with the baby and of course be responsive to the baby's needs. So the best time to feed will be kind of those quiet alert phases where the baby's not exactly crying. And then you're going to find it's going to be much easier to wake up the baby and feed the baby. If your baby's out like a light and it's about time for the feeding, you also can wake them up. You can try to do massages. You can try to even kind of tickle the hands, massage the feet. You can even try to stimulate like rooting reflexes by taking their hands, massaging it, bringing it closer to their face, changing the diaper, taking the clothes off, putting the baby skin to skin are all wonderful ways that you can help to feed the baby. Now, what do you think if you feed the baby and they wake up immediately crying? Now, remember our feeding cues. So crying is a late stage hunger cue. It's not an early stage hunger cue. So if you know that you fed the baby had something, you put the baby down and they're immediately crying, what does that tell you? It's probably not because of hunger. It can be because of stimulation or even sleep, like the baby's sleepy. So you want to note your feeding cues. So if you feed the baby and then put the baby down 10 minutes later, they're crying. And a lot of times they go, oh, see, the baby's not full yet. A lot of the times it's simply because the baby's overstimulated or needs to sleep. So what you can do is try swaddling, swaying, shushing, and sucking, all of the S's, swaddling or even skin to skin. Swaying, so repetitive movements, and shushing or repetitive sounds. And then sucking, either finger, pacifier, breast, bottle. We just try only really not to overfeed. So the sucking really more than anything, we try to work with the first three. And then if all else, fails, and then we can go from there. So these are my top 5 breastfeeding positions. Now there's different similarities between them all. The number one is that the baby is always belly to belly. The one position, although I do like this chart, but the one position that's a little off is the sideline position here, because instead of the baby being on the back like this, the baby should actually be on the side. So the baby's belly to belly. But as you can see, cradle position, cross cradle position, football hold, even the laid back position, the baby's belly is always going to be facing mommy's belly. The baby is always going to have a hand on each side of the breast, almost like a hamburger. And the baby's body is always going to be aligned when it comes to the head, shoulders, and hips. So when you turn your head this way and you try to swallow, it's a little difficult because it feels closed. It's the same thing with the babies. So we want to make sure that the baby's in alignment. Head, shoulders, and hips. Baby's always belly to belly. Baby's always going to have a hand on each side of the breast. We don't want to go like this because then we're kind of blocking. So we want to make sure the hands are on each side of the breast. Baby's belly to belly. We also want to make sure that we are supporting baby and mommy. So how does baby need to be supported? Baby's hips and feet need to be supported. The back needs to be supported as well. For mom, she can use some pillows, kind of help her that way. Now, top 5 positions. I'm going to go over like each one and what are the benefits of each one. So for cradle, cradle is good once the baby kind of gets the handle of latching. With the cradle, it's the typical position that most people use. And this is my son's teddy bear, by the way. I hope you like it. But typical cradle position, baby is still belly to belly, head, shoulders, and hips in a straight line. And then mom either can take her breast like this, tip the nipple up a little bit, and then baby can latch on this way. This is a very baby-led position. What I love, especially for newborns, is the cross cradle position. With the cross cradle position, your hand making a C around here, and you can actually tip the nipple up as well. You're having some pillows underneath here, pillows underneath here. Notice baby is at level of the breast. A lot of times people kind of go like this with the baby like sitting down. Baby's at level to the breast. What we're gonna do is bring the baby up and over. Notice where my fingers are. My fingers are at kind of the ears with some gentle pressure here of the shoulder blades. So my palm is kind of resting in the shoulder blades. My rest of my arm is around here, and I'm gonna be able to bring the baby up and over. This is a really great position if you have a baby that has a shallow latch or is having difficulty opening really wide or having difficulty kind of with coordination. So this is a great way that you can be able to latch the baby on a little bit wider. This is a very mother-led technique. Another position that I really love is the football hold. That is where you have the baby kind of to the side. Now for this to work, you need pillows, lots of pillows to have the baby up high like this. Football hold is not like this. A lot of people, they do the football hold and they kind of have the baby down and bring the baby up. You want to bring the baby so that the baby's kind of tucked here, sideways, belly to belly, and you bring the baby up and over like this. This is a great position for moms who have cesarean births, for example. Another great position is a laid back. With laid back, what I love to do is I love to kind of do the cross cradle and then lay back. It just helps to have a kind of a better positioning. Then you even can lean back like this, or you can even kind of switch your arms around once you lean back, or some people like to lean back like this. Lean back is literally like you are leaning back like a 20, 30 degree angle, almost completely back. What that's going to help with a lot of the times is an oversupply or a fast letdown. Sometimes that helps by gravity, keeps the mouth from like just gravity, everything coming in because the baby's on top of the breast. That also helps if you have a lot of damage to your breast. That can help to kind of heal the area so you're not causing further damage while we get the latch kind of figured out. With all of these positions, you can always ask a lactation consultant. You can contact me as well, mommydidyouknow@gmail.com, or leave a comment as well. I do accept insurance plans. So for both virtual and in-home consultations. And a lot of the times your insurance covers lactation support for free. So keep that in mind also. Side lying, I love the side lying position. Side lying was great for an oversupply as well, because if your baby, if it comes out too fast, the baby can kind of just dribble it to the side. The only difference between this diagram and the actual side lying is that the actual side lying, the baby will be facing you. This is a great position for moms who have a perineal tear or vaginal tear, especially if they have a lot of perineal pain. This is a great position that they can keep the pressure off of there. So here are some of my favorite techniques. And of course, there's different ones as well, but these are very, very important. Why is it important to position the baby correctly? Now, positioning literally is like 90% of the work when it comes to latching your baby on. When your baby's positioned correctly, everything else flows into place. So they're in alignment, they're more likely to nurse, they're more likely to latch. So try to keep the baby in position, and you're going to notice that it's going to be much easier to latch the baby. Now for the latch itself. A baby with a poor latch can have difficulty transferring milk. So that's why sometimes they might have trouble gaining weight. They might have also, sometimes you will have signs of dehydration depending on the severity of the case. So you want to know that the baby's latching well so you can have confidence that your baby's eating, because there's no gauge on the breast to go ding, 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 your baby has drank 1 ounce. Yay. You kind of have to gauge it off of your comfort level, baby's comfort level, as well as some behavioral little aspects. Now, signs of a good latch. Nipple shape. Your nipple shape should be the same before and after the feeding. If your nipple shape is different, that can be a sign that the baby might be on too shallowly. It should be the same shape, maybe a little bigger, but you should not have like a pointy nipple or anything like that. The mouth shape of the baby needs to be like an over not just the nipple, but the areola also. and mom's comfort level. If mom is having any pain whatsoever, definitely get a lactation consultation so that you can kind of get a look on what's going on. Mom should not be having pain. It can be feeling like tugging, but not like pinching. You should see swallowing. So you'll see the baby kind of rapid and shallow. Then as letdowns start to happen, you'll start to see some slower, deeper sucks with swallows. And you'll see swallows because kind of here will move, and you'll see some like small pauses as the baby's swallowing. You'll see the temples moving as well as the whole jaw is moving. And diaper changes. That's one of the best ways to tell that the baby's eating well is by diapers. We have some good ins, we have some good outs. So diaper changes for the first few days, it goes by the days of life. So P's according to the days of life. First day of life, you want at least 1 P. Second day of life, 2 P's. Third day of life, 3, 4, 4, 5, 5, 6, 6, 7, 7. You get the idea. After the first week, it's about 5 to 6 P's per day. Poops, it sets at least 1 poop for the first day. And then after that, it's about 2 to 3 poops per day. It should also kind of it should change a little bit because you're going to see a little bit of a transition from that black and tarry meconium to that yellow and seedy stool as the baby gets, all that meconium out. So it's going to be black and tarry, then it will be green and transitional, then it will start being yellow and seedy. So you want to see that transition of the stool happen. You don't want to have cracks, you don't want to have pains, and no clicking as the baby's nursing as well. Clicking or pain can be shallow latch or even a tongue tie, lip tie. So if you have something like that, check with your pediatrician, your ENT, pediatric dentist. Sometimes pediatricians don't look into it as far as much as like an ENT specialist or a pediatric dentist. So if let's say it was missed at the pediatrician, you might want to get a specialist hand on that as well. Lactation consultants, we can tell you when it might be a good idea to look into getting it assessed. However, we cannot typically diagnose a tongue tie. That would only be from a medical doctor or, physician, a dentist, something like that. But we can assess and say, hey, it looks like it might be this. So if you have questions, you can always leave a comment, send me a message as well, and I'll be more than happy to help you guys out. mommydidyouknow.com is my website with more consultation information. Now for basics of latching, we always want tummy to tummy alignment, nose to nipple as well. So when we're putting the baby to the breast, we don't just shove the breast into the mouth. What we do is we kind of tickle the nose a little bit with the nipple. So we're tickling the nose so that the baby opens, and then we bring the baby up and over. I also like something called flipple, where you flip the nipple up so the baby opens more wider and comes up. And then you can also compress with feedings and make sure that you relatch if needed, that you don't just keep it. And then that goes into here. What do you do if you suspect the baby's not latching well? This is, by the way, Nathan, so he's my second born. So if you suspect that the baby's not latching well, make sure that you take the baby off and then latch the baby on again. You don't want to just keep it because then you can end up with more issues. Now, here are some common difficulties and how to overcome them. So one, difficulty latching. So signs of difficulty latching can be compression stripe, baby is fussy at the breast, you have pain, unable to drain the breast as well. Treatment can be, number one, position changes. Once you start positioning the baby better, everything else just flows into place. We also want to treat the nipple soreness, especially if you're having painful latches. So that can be having gel pads, having creams as needed, air drying, hand express into the breast, and then just air drying. We want to make sure that we are preventing further damage to the breast as well by making sure the baby is latching well, maybe even doing the laid back technique. We can also treat soreness by seeing if it's something besides just the pain on the breast, such as yeast infection or candida on the breast. So if you have continuous soreness on the breast that's not going away, or if you're having bleeding, you can also ask your doctor to see if it might be something a little bit more in depth. Or sometimes mastitis can come in as the baby's not draining the breast, and then it can cause an infection as well. Assess for causes of the latching. Is it from developmental issues? Is it from tongue ties? Is it from position changes? It's very easy. Sometimes difficulty latching is very easy to correct. Sometimes it's a little bit more difficult. Is it from inverted or flat nipples? Maybe we have to work the nipples a little bit. Sometimes we need to use hand compression to kind of bring the nipples out if they're flatter or inverted. They even have these little suction cups called Latch assist where you can help to get the nipple out. Sometimes we might need to start with a nipple shield, get the nipple out a little bit more, and then kind of transition to not using it. Or sometimes we need even speech therapy or OT therapy to kind of get the baby a little better. Another huge obstacle a lot of people face is engorgement and oversupply. I actually faced this with my both of my kids. Actually, I suffered from engorgement a lot more with my first baby. And that's actually the reason I became a lactation consultant. So if you're dealing with engorgement, definitely look into lactation support. But here are some other things you can do. So signs of engorgement can be hardened areola, hardened breasts, you get painful swollen breasts, mastitis as well, fussy baby, green stool, especially explosive poops as well. With engorgement, sometimes you might have recurrent mastitis, which is what happened with me as well, when you're getting continuous clogged milk ducts that are not really being transferred that well. Treatment can be block feeds where you're only feeding one side per feeding or for a certain block of time where the baby's going to fully drain the breast before going to the other one. So sometimes we have this like timing thing where we're like, all right, I'm going to put the baby 10 and 10, but the baby did not finish the breast completely in 10 minutes. So then what ends up happening is you end up with engorgement in here and engorgement in here. So sometimes if you have an engorgement so bad that your baby cannot finish the feeding with only one feeding and still leaves the breast full, you might even need to have more than one feeding on the same breast. So that is something that you can definitely talk to a lactation support about. Reverse pressure softening is something else you might need to do. That's when you're so engorged that your areola becomes dense and hard and non-compressible. And sometimes you have to have some reverse pressure to soften the areola up more. And then that will be to allow the baby to latch on. You can reverse pressure soften by your hand, kind of pressing back like this, reverse pressure, or you can use a hand pump. Sometimes that helps as well. Reassess the latch, make sure the latch is good, and then heat before, cold after. Now we have the other end of the spectrum. Let's say we have a low milk supply. Let's say baby shows signs of dehydration. Let's say we have poor weight gain. Let's say we have frequent need of supplementation. What do we do to increase our milk supply? One is, of course, you reassess the latch. You want to make sure that the latch is open, the latch is wide, baby is transferring milk effectively. We want to have frequent stimulation to the breast. We might need to stimulate even more depending on how much stimulation the baby is doing. So let's say baby is not latching well, very sleepy, falls asleep on the breast, and then is not really transferring milk that effectively. We might have to incorporate pumping sessions in there as well to kind of increase the stimulation to the breast. So your breast should be stimulated about every 2 to 3 hours. So the more that the breasts are stimulated, the more the milk is released. So we might have to have a little bit of breastfeeding, a little bit of pumping, depending on the situation. Supplements as needed. Not only they have fenugreek, and I know that there's a lot of kind of discussion about that, but they have other stuff too. They have fennel, they have goat's root, milk thistle. So they have a lot of different supplements that you can use. And if you have questions about that, please, you can drop it in the comments as well. I'd be more than happy to answer that. And then another great treatment for low milk supply that I love is supplementation from other methods besides just the bottle. So a lot of people, if they have a perceived low milk supply or a true low milk supply, they tend to go straight for the bottle. However, there's other ways that you can offer supplementation. And I would love to do another video about that as well. But one of them, for example, is an SNS system or supplemental nursing system, where you have the supplement actually at the breast instead of from a bottle. So as the baby's nursing at the breast, you can have a tube that comes out that's connected to milk that the baby will be able to drink extra milk straight from the breast. They also have cup feedings, we have syringe feedings, spoon feeding, finger feeding. So there's a lot of different things. Now, let's say we have a lot of pain while we are latching. What are some things that we can do to kind of combat that pain? One is you want to look at the the source of the pain. Is the source of the pain from something anatomical? Is it something behavioral? Is it something mechanical? Can we fix it? So let's say the source of the pain is that the baby has a tongue tie. Maybe we have to do some oral exercises to kind of release the tongue a little bit. Let's say we might need to do a correction. If we need to do a correction, make sure you're working with a lactation consultant, maybe even speech OT as well, to kind of do some body work and loosen up the tongue a little bit more. Let's say you're having pain because it's mechanical. Let's say it's just the way that you're putting the baby to the breast, positional. Maybe we have to switch that up. Let's say it's behavioral. Maybe we're having pain while latching because the baby is freaking out by the time we put the baby to the breast and we need to offer the breast a little bit sooner. So there's different reasons that babies might cause some pain while latching. So we have to think about the source. Once we know the source, and then we can definitely move on a lot better. Now, the last section we want to go over is pumping. A lot of breastfeeding moms end up pumping either intermittently or in combination. There's reasons to pump. Biggest reason, separation. So let's say there's a separation between you and the baby. A premature baby will want to increase the stimulation. Let's say breast surgery, you had a reduction or augmentation and you want to have some extra stimulation. Then of course, supplementation. So the main theme of this is the biggest reason to pump is for stimulation. Now, how to pump? We're pumping for stimulation. The easiest way to remember is whenever there's a missed feeding, you don't want to just skip the feeding. Instead, you would try to pump. Or if we're trying to stimulate more, you can pump intermittently in between your feedings as well. So how to pump? Frequency. You want to make sure the breast is stimulated at least every 2 to 3 hours around the clock, especially until your milk supply is established. You don't want to go too long without stimulation. Duration, no more than 15 minutes, honestly. The majority of women can take the majority of their milk out in the first 10 to 15 minutes. If you are having a long time in order to get the milk out, maybe you have to change the flange sizes. Your flange size is basically your nipple shape, and then you add 4 mm, and then that can be your flange size. If your flange is pulling too much of the areola as you're pumping, that means you need to go down a size. If your flange is pulling too much of the nipple, like as if the nipple is hitting the walls, that means you need to go up a size. So we are stimulating the breast every 2 to 3 hours for about 15 minutes tops. Lots of hand compression. That's the biggest technique. Lots of hand compression. Don't just sit there idly by. Active pumping is one of the best things that you can do. You can try to smell the baby, see the baby. You can try to hear the baby. There's even meditations that you can do to kind of increase your milk supply. What do you do if you feel like you are not producing much? So I hear this question all the time. Now, the most important thing that you can do is not to be discouraged and continue stimulating. It only takes a little bit of time for you to really start making a difference. So continue stimulating, lots of skin to skin time. We can put the baby to the breast when possible. You can try to make sure that your flange is the appropriate size and also that your settings are good. When you first start, it's very rapid and shallow. You want to have the high frequencies, low vacuum. You don't even need to have the vacuum too strong, just kind of stimulate 30 to 45 seconds. Then about 3 to 5 minutes of that kind of deeper compressions, and you're going to notice a huge difference there. If you have any other pumping questions, feel free to let me know. Extra resources. I have a lot of resources. I have free support groups. I have virtual ones. I have in-person ones. I have breastfeeding classes on my website. I have childbirth classes on my website, in addition to private ones. So you have online ones, private ones. A lot of insurance plans do cover my classes, my resources as well. So if you have questions, you want consultations, feel free to let me know. You can also subscribe. Please don't forget to subscribe, because that is a great way that we can help to grow this channel and get this amazing resources out to those who really need it. So feel free to subscribe, like, comment if you have any questions below. You can also contact me. My website is mommydidyouknow.com. My email is mommydidyouknow@gmail.com. You can also leave me a comment and I'll be more than happy to respond. I hope you have a wonderful rest of the day.